Hi, everybody, and welcome again to SCAI's Conversations in Interventional Cardiology. We're really excited to be live here at VIVA 2025. My name is Sahil Parikh. I'm one of the associate editors of JSCAI and an interventional cardiologist at Columbia University. I'm really excited to be joined by a live all-star panel of friends and colleagues as we talk about chronic limb-threatening ischemia. To my right, Dr. Eric Secemsky from Beth Israel in Boston. To his right, Ehrin Armstrong from Denver, interventional cardiologist both. To Ehrin's right, Venita Chandra, vascular surgeon and faculty at Stanford. And to her right, Dr. Saher Sabri, interventional radiologist, all members of the VIVA board and thought leaders in the space. We're delighted that JSCAI has been able to publish 2 manuscripts in tandem from the VIVA group, reflecting on the importance of chronic limb-threatening ischemia. Without further ado, I'm going to invite Eric to present the summaries of those 2 papers, and then we're going to have a little bit of a discussion.
Great. Thank you, Sahil, and wonderful to be able to do this collaborative effort with JSCAI, who's been so supportive of our documents that came out of the Vascular Leaders Forum, sponsored by VIVA in April 2024. So these 2 documents really were meant to contextualize where we're at with CLTI care in the U.S. It brought together a multi-group of stakeholders that included all different specialties in the vascular space, as well as the private strategic partners that really deal with the day-to-day development of our devices, and our regulatory body, including the FDA, who were in attendance of these sessions. So these 2 documents were really preceding documents to summarize the content that were discussed in this closed-door meeting. So just to highlight, this is a 2-part series. The part 1 was really focusing on the efforts to move towards collaborative care for vascular disease. And you can see our diverse group of lead authors here representing not only the VIVA board, but all specialties in the vascular space. The second document really dived in a little bit more into what's necessary as we develop the clinical programs moving forward to evaluate the devices and strategic approaches to caring for patients with chronic limb-threatening ischemia. Now, when we talk about multidisciplinary care, one theme that came up over and over again throughout this closed-door session was the urgency to act now. I think that we've all recognized, in particular the last 5 years, that there is a growing epidemic of amputation that's occurred throughout this U.S., that our comorbidities that lead to amputation are out of control: diabetes, tobacco use, obesity, and that without collaborative, cohesive efforts, we're never going to make a true impact on vascular care. The challenges in particular were focused on disparities in access. We've had a lot of disparities throughout the U.S., both from a socioeconomic level, but even just a regional, rural, urban level. We've seen declining reimbursements, obviously fragmented collaboration efforts among vascular specialists to give the best optimal care for patients, and poor patient outcomes. And really the key effort of the session was to focus on multidisciplinary collaboration. And so this figure here, which is nicely demonstrated in the document, and I'll show you this again here, is really the main take-home point of this document was we all represent different areas of the ecosystem taking care of vascular patients, whether this is in a big hospital system, a smaller community hospital, a privately owned outpatient clinic, or even in the primary care office. And these are all the main participants in vascular care that need to really collaborate and work together to be able to advance the efforts on behalf of our patients. One thing that came up was a little bit about the patient itself. I think we don't get enough data from our patients, and we discussed a lot about really where our limb salvage cases were happening and how often were we collaborating among a group. So we did some polling throughout that session, and you can see here there was a lot of variety, even among willing participants to come sit in a room amongst each other, about how often we're discussing collaborative care at our home institutions. And you can see even the collaboration across specialties was really prioritized. I think everybody felt the need to advocate for more limb salvage teams and collaborative efforts, but as you can see in that pie figure, it wasn't happening as frequently as we want. The other option here was what's the right treatment strategy, and we still have a lot to learn about the focus on our endovascular therapies and the durability, but also the access issues that come with surgical treatment and how this may not be allowed for all patients, in particular when we have such a dearth of vascular surgeons available in the U.S. The second session that was part of the Vascular Leaders Forum is really an important part of thinking about how do we move forward with the clinical device trials in this space. You know, I think we all have an ideal mind for a clinical trial where we really want to reduce the most important endpoint, amputation and mortality, but we're also practical in the sense that we can't necessarily get the sample size or the right patients to find that type of signal. And so we have to really think outside the box on what are the important endpoints that we can capture, and then also get these studies funded to be able to generate the data to move this field forward. So these 4 themes came up: endpoints, inclusive enrollment, extending the follow-up, is it 12 months, is it 5 years, and then also the innovative aspect of trial design that we are continuously talking about now, pragmatic trials, different ways to look at endpoints so that we don't have to wait 10 years to get an answer. I think from the FDA standpoint, we got a really nice perspective as summarized in this table about what they're looking for. You know what I mean? I think that's a big part of this is in the negotiation with our regulators to make sure that our trials can be implemented and approached in the U.S. in an efficient manner. And then also, we kind of talked a little bit about how we move forward with clinical trials in the future. The day of the old school randomized trial, those come and go, but we really have to be able to be nimble and think about really evidence development through other pathways. And so we talked about registry studies, registry-based randomized trials, and even this idea of emulating or mimicking a clinical trial in observational data. So again, we're really thankful to JSCAI for partnering with us when these preceding documents were available. I think that this really is a cohesive effort among the VIVA board as well as our vascular community to really advance care for patients who are in great need. Thank you very much.
Eric, thank you very much. And again, we're going to reflect on some of these things that you've brought up now in the next few minutes. I wanted to first ask you just some demographics. How many people were at the VLF, and what were their sort of specialties?
Yeah, so the VLF had just around 50 participants. It was an invite only and as recommended from the VIVA board and our team here. And as really consistent with the mission of VIVA, we had equal representation of all major vascular specialties, vascular surgeons, interventional cardiologists, interventional radiologists. We also had vascular medicine specialists, podiatry, but also in the theme of the vascular leader forums that we've had in the past. As I mentioned, we had the FDA participating, and then we had company representatives for the major companies that make our medical devices for vascular patients. So it was really a unique multidisciplinary group that had many different shared perspectives. And last, I'll highlight, we had a patient representation as well, and that was really special to have the patient there and tell a story with his son, and that was an impactful moment for all of us.
Terrific. So I think one of the important issues that you brought up was the need for cross-disciplinary collaboration. You really tried to get all the stakeholders there. We have a great multidisciplinary panel, so I want to get the input. You showed that the sort of the pie chart with respect to how frequently collaboration exists, even amongst the coalition of the willing that was represented at the VLF. So, Ehrin, I want to ask you, in your clinical practice now, how often do you think would be the optimal amount of collaboration as a vascular team? Weekly, daily? What do you think?
Yeah, I think there's 2 ways that the collaboration functions and works best. I think one of them is an often daily interaction, especially when you have patients who are admitted to the hospital perhaps and are being seen by a combination of a vascular specialist, perhaps vascular medicine and often podiatry or other wound care. That's kind of a natural collaboration that happens in the setting of treating these patients acutely. But I think there's a ton of value to doing a regular, even if it's a virtual like Teams meeting, that's a wound-focused and vascular-focused cross-disciplinary collaboration. It gives an opportunity to have a touch point, I think ideally on a weekly or every other week basis, and creates some more opportunities, I think, for collaboration across the specialties as well. So that's been my experience, and I try to do that with my podiatric colleagues in wound care, and I've been trying to roll that into a multidisciplinary fashion.
Yeah, and Venita and Saher, both for you, the same sort of question, but really with a twist. In terms of the competencies that you see that are most lacking in your venues of care, what's the hardest part of that circular diagram that Eric showed us to find both in academic as well as in clinical practice?
Yeah, great question, and a challenging one, because politics are local, right? And I think in every multidisciplinary sort of limb salvage program, the makeup and the people that are involved are different. In my opinion, what is the most important, to answer the opposite of your question, is and like a true advocate, at least one or two people or specialists that are really advocating for all of that. What I have the most challenge with actually is on the sort of infectious disease medical management side that gets quite complex. And we don't have, at least in our system, we don't have it as involved in a regular basis. I like what Ehrin said about if we could all meet and talk at least daily or weekly, it would be really wonderful. But I'm one of those sites that monthly is as good as we can get it.
And Saher, how about in your venue as an interventional radiologist? What do you feel is the most difficult competency of those many competencies that we need for the care of these patients?
Yeah, I mean, I think one thing I want to focus more on is the education piece, because I think as we try to kind of level set and have most of the trainees, talking about academic centers, all the trainees coming out of the competency. So one of the things that I think we've been working on and we would like to see more of, which is to have trainees trained with other programs, with other cross-specialty. I think that is a great thing. Having joint conferences, whether it's discussing case discussions or journal clubs. And I think things like this, it helps build the trust and helps actually, kind of level set the education piece. And I think that definitely builds up. But yeah, there's, different exposure. I mean, to see how different things are done by others, I think it just builds that trust. And I think that just, makes it much easier to collaborate.
All right. Well, I mean, I think there's just many, many things we can talk about. I encourage you to look at part one to really understand some of these landscape issues. So let's move to the clinical trials piece. Eric, you're a trialist in your DNA. From an endpoint standpoint, we've always struggled in this CLTI patient population to have adequately powered hard clinical endpoints, as well as other surrogate and or patency-related endpoints, which are dovetail more with the technologies that we presently have. How do you think that we could overcome that with real-world evidence? Because I know that's one of your sort of missions in life.
Yeah, we talked a lot about the challenges for clinical evidence generation in the afternoon session. And, the ecosystem for clinical trials right now are challenging. We kind of spent some time thinking about the fact that most of our clinical trials end up getting funded to get a device on the market. And the regulatory requirements may look very much different than the clinical needs we have when that device is on the market. And then we look at the post-market space and we say, well, we want to run this clinical trial, and CLTI is a great example of it, but we need money and we need some organization to help us conduct it. And that isn't as easy to find. CLTI was a challenge to conduct. It took a lot longer than they wanted. There was fundraising that had to happen to get it over the finish line. And so the ecosystem for clinical trials in the U.S. in particular is challenged. So then we have to think outside the box. And so to your question, I think not even getting into the nitty-gritty of the endpoints, but how do we take lean clinical trials and make them more robust clinical evidence? And we've talked a lot about embedding clinical trials in registries, linking to real-world evidence like insurance databases to get hard endpoints like death and amputation over the long term, far after the original trial ends. So there's a lot of unique aspects that are discussed in the second part of that document that move the needle forward a little bit about how we think about clinical trial development in the future.
Well, I mean, I think it's an incredibly complex area. Venita, I want to ask you and sort of better understand what is the landscape like for clinical trials. You're a principal investigator of a number of trials. Why is it so difficult to enroll in these trials? What are some of the challenges, especially in the CLTI population?
Yeah, I mean, we all know the complexity of these CLTI populations, and for a trial to be able to make sense to us, to get anything out of it, we have to compare apples to apples. And that simple task, I think, in CLTI patients is nearly impossible. They're so nuanced, they're so complex. And so what happens in our design, in order to make sure that we are comparing the right things, is we have to limit so many aspects of it. And so while then we can get a well-organized trial design, but it really limits the patient population that we can enroll. And then it also limits the impact in terms of, well, is this real world? And so we have to really balance, and that's where I think some of these more creative options of research will come in. We have to be able to balance actually being able to roll and understand something out of the trial with what our practices are really like.
And can I just add to this? I think this was something that was really nicely illustrated in the paper in that part two, talking about different ways that or recommendations of how to be more inclusive in the trials. You know, how to try to make it more emulate real world. When people look at a study, they say, yes, can this apply to my population, or not just to discard it saying, oh, this is a very select population. So there's some really specific recommendation about not having the majority be Rutherford 4, for example, including some Rutherford 6, but these not be the extreme, but just certain types of Rutherford 6 that don't have active infection and don't have extensive tissue loss. So there's certain aspects that we can do to make this more real world, also increasing the diversity of the patient population. You know, for example, excluding all patients with dialysis, that's an issue. I know, for example, Life BTK was used as an example of how to improve in accessibility to trial to patients from a diverse background. So I encourage everyone to read this paper, because it gives a specific recommendation of what can be done to increase the diversity of the population and make it more real world.
So Ehrin, I'm going to give you the last word. I think coming out of the VLF, having attended many of these before, there's always this sort of euphoria, and then there's this reality about how do we execute on this. I want to both thank and congratulate the VIVA group for trusting us at JSCAI to present these conference proceedings, but I wanted to get from you, what was your overall sense as you left the VLF, and tell me a little bit about your optimism for where we're going from here.
Yeah, I mean, I think the VLF is a great forum. We try to do it, if not every year, at least every other year. And each time we choose a topic, I think, that is of paramount clinical importance. And so I think it was really wonderful to have CLTI focused on during the VLF session. And it really brought together a lot of unique stakeholders, both from the multidisciplinary clinical perspective, but I think there was also a lot of value to have the FDA there and also some of the payers as well. And I walked away from it feeling enthusiastic about the future of treating CLTI and the fact that we're actually really focusing on how to conduct clinical trials in this very complex cohort of patients, and how we can try to do better from a multidisciplinary perspective as well. So I think that these two papers, I think, are a wonderful summary of what we discussed there, and they do, as Saher mentioned, provide a roadmap, I think, for some ways that we can actively move forward and improve the care of these patients.
Well, I want to thank my world-class panel for being here with me live, and I want to thank all of you for watching. We look forward to seeing you back for more conversations in interventional cardiology. Please check out both manuscripts on the JSCAI website, and we look forward to seeing you soon. Thanks again.